we have various working elements and cutting loops. The cutting depends on the diameter of the element, the thickness of the wire, and the current intensity what you are passing. As energy source itself is a class, we will discuss it in the some other class, but briefly, there is no separate current like a coagulation current and cutting current. It is misunderstood. Many people think there are two different currents. Coagulation current is different, cutting current is different. It is not like that. Current is same. By choosing the frequency and the amplitude of the current, you can get the function either you are coagulating or cutting the tissue which is in question. And you should be master to cut, and if you see a spurter in the same sitting, you should coagulate. So this is a procedure where a submucous fibroid we are resecting. The stroke should be from above downwards. You should resect bit by bit. It is a cutting mode we are using. There will be universal probe which passes the current, and the entire surface you have to coagulate. Once you have coagulated, you have to reduce the flow and see whether there are any spurters. If there are spurters, coagulate them and revisualize. Unless you are 100% satisfied with your hysteroscopic coagulation, don't conclude the procedure. Because when the fluid is getting pumped at a high pressure, if it exceeds 100, all the bleeders will look as if they are not bleeding. Instantaneously, the bleeding stops. You may be in the false impression that there are no sputters, but when you reduce the flow, once it gets reduced below 60, all the sputters will start bleeding. So the message to my young students, reduce the pressure, see the sputters, coagulate, secure a good hemostasis, then only you conclude. So coming to the second generation endometrial ablation technique, also referred as seed technique. These are simpler, quicker, and they do not require hysteroscope, and they get the results of transcervical resection of endometrium by different ablative techniques. In this comes the fluid filled balloon, radio frequency thermoregulated techniques, microwave endometrial ablation, and cryoablation. When you compare these two techniques, the first generation techniques are usually performed under general anesthesia, whereas second generation endometrial ablation techniques can be performed under regional anesthesia, and the first generation endometrial techniques are very heavily dependent on the operator and also on the instrument to large extent, whereas second generation, it is independent of operator, it is mostly dependent on the instrument. In other words, to perform transcervical resection of endometrium, you should start doing diagnostic hysteroscopy. After good number of hysteroscopic diagnostic procedure, you should start doing resection of small polyps, then small submucous myomas, and then transcervical resection of endometrium. The hysteroscopic operative procedures are more difficult to learn compared to laparoscope because the cavity is small, and when you pass the current, there is a possibility of injury or perforation to the uterus and adjacent organs. But it is not difficult. Once you determine to do it, you can learn. To overcome this difficulty and a long learning curve, second generation endometrial ablation techniques have come, which are instrument dependent. Even the beginners can perform it very safely, and the learning curve is very short. In first generation endometrial techniques, hospitalization is required, whereas second generation endometrial techniques, these are outpatient procedures. The complications are more common in first generation, like electrosurgical burns, uterine perforation, post-operative bleeding, possibility of infection, pain, all these are there. Whereas in second generation, relatively the complications are much less. Main complication is post-operative pain or rarely the perforation. Coming to the cost effectiveness, because of the instrumentation and the imaging technologies, the first generation are expensive. Second generation equipment is expensive, but at the recurrent expenditure is comparatively less compared to the first generation. Now here I will show you some of the procedure. Laser energy, laser interstitial hyperthermy. Here the device uses a fiber instrument. It destroys the endometrium up to 1 to 3.5 centimeter adjacent myometrium also. In other words, it destroys the endometrium as well as adjacent few millimeters of myometrium, and the treatment time lost 5 to 7 minutes, and in 1 year 70% of the women will become amenorrheic. The energy source is laser, and the patient satisfaction is almost 80% in these techniques. The second technique is, and one more point is, in these procedures, non-ionic low viscosity, wait 1 minute. The second technique is hydrothermal ablation technique. In this, normal saline is used. The destruction of endometrium is up 2 to 4 millimeters. There is a microprocessor control temperature, inflow and outflow. In this, the temperature utilized is 90 degrees centigrade. The entire procedure takes 10 minutes. The intrauterine pressure will be 35 to 50 millimeters of mercury. Once the procedure is over, we have to give 1 minute cooling time. In other words, once the procedure is over, when there is a indication the procedure is over, immediately you should not bring the probe. Otherwise, it can cause burns to the vagina and the labia. So you have to give 1 minute time, keeping the probe inside to get
After a
it
slight
cooled.
dilation of the cervix.
So you gently pass the probe and use the normal saline, which is heated to 90 degrees centigrade, and the entire endometrium gets ablated. Dr. Sarita, is video visible?
Yes.
Okay, thank you, sir.
Yes,
So,
we can see the video.
okay. So here the endometrium gets burnt. You should wait patiently for 10 minutes. Once the procedure is over, you will get a blip. The fluid inside gets circulated and the entire lining will get ablated. You should patiently wait for 1 more minute, then bring out the probe. When it is analyzed, nearly 50% of the patients will become amenorrheic in 1 year. Hypomenorrhea is achieved in 16% of cases. Another 16% will have eumenorrhea, and 1 in 5 cases they may not get the relief as much they wanted. The other technique is cryoablation technique. In cryoablation technique, the mechanism is extreme cold is utilized to destroy the endometrium. It takes 20 to 30 minutes. This device uses compressed gas mixture to achieve minus 100 degrees centigrade. In the previous procedure, we used 90 degrees centigrade. Here, minus 100 degree centigrade cooled nitrous oxide or any other gas mixture. This is delivered through a cryoprobe, which is about 5.5 mm. This probe is marked with centimeters. So you should measure the uterocervical canal length gently. Up to that length, you should gently pass the probe. Sonographic monitoring is essential in this procedure to provide a safe area between cryozone and serosal surface. So in every case, taking proper history, proper examination, having an ultrasound is mandatory. I'm just discussing the pros and cons of the procedure, but underlying basics are same in every case. So you should know the uterocervical canal length. You should have a clinical acumen of bimanual examination, the cavity details through transvaginal ultrasound, then gently pass the cryoprobe. As I told you, you can notice the probe is having markings. Then on each side, you reach the corner and start cryoablating the endometrium. Usually it is done in 2 to 3 places to achieve the entire endometrial cavity. The entire procedure may last for about half an hour. Usually it is an outpatient procedure, but if the patient is having any cramp-like pain or she asks for some sedation or analgesia, we have to provide. And all this area gets sloughed off and eventually she becomes hypomenoric or amenorrheic. Another method is NovaSure impedance controlled 3-dimensional bipolar endometrial ablation system. In this, histoscopy is not necessary. It uses a disposable 3-dimensional fan-shaped expandable bipolar device composed of a porous metallic membrane draped over metallic skeleton. After introduction into the uterus, it is deployed from its protective plastic sheet. Through radiofrequency generator, the current is passed. So in this also, you should have a proper ultrasound, and once the procedure is started and the current is passed and ablation is achieved. Once the ablation is achieved, you have to withdraw that fan-shaped metallic membrane and gently bring it out. So it is very useful. The patient satisfaction rates are very high in this procedure, up to 90%. 1/3 of the patients become totally amenorrheic. The contraindications are if the cavity is too small, less than 4 centimeter, or too large, more than 10 centimeters, and if there are any submucous fibroids. Now let us discuss about 3rd generation endometrial ablation techniques. The thermal uterine balloon therapy techniques involves insertion of the balloon tipped catheter into the uterine cavity, and then through this pass a heated fluid, either 5% dextrose or saline, and then with this heated balloon, the endometrial ablation is achieved.
A compact and portable system that could...
So in this, the entire time taken is about 8 minutes. The fluid utilized is 5% dextrose. As we have discussed, all these procedures are instrument dependent, less operator dependent. This gives computerized feedback. You have to just watch the monitor. The few practical tips are, this balloon, you have to insert the syringe first, withdraw if there is any air. Then once the balloon collapses, gently you will insert the balloon into the uterocervical canal. Once again, you have already examined the patient clinically and you have an ultrasound and you have an idea what is the uterocervical canal length of the patient, and you have a, most important is the biopsy report. It is mandatory to have an endometrial biopsy before you do thermal ablation techniques. The entire procedure takes only 8 minutes. But believe me, when we are doing this procedure, that 8 minutes looks so big because you are not doing anything. You are just holding the balloon and waiting. So it looks very long time. But in 8 minutes, the procedure will be completed. What you have to do is, the syringe is attached. Once you push the dextrose into the balloon, it shows the pressure 160 and plus. You maintain the pressure between 160 to 180 millimeters of mercury. Once the balloon expands with the temperature, if the pressure reduced, you gently push few drops of dextrose and that pressure is again maintained. The aim of the operator is to maintain the pressure intrauterine between 160 to 180 millimeters of mercury. Then the uterine sloughing starts next to 7 to 8 days. Let us see the procedure. The computer display shows come repeatedly to the hospital for the follow-up. But one caution is, you have to explain to the patient, after this, she cannot plan a baby. Why they should not plan a baby? Write your answer in our chat box. In the end, I will see. Over the thermal ablation techniques of balloon, we have one more advanced technique. This is called as cavatum. In 1990, Professor Hans Wallstein has devised this. This has evolved from the thermal balloon technique from level 1 to level 3. This is made up of silicon. Earlier balloons were made up of latex balloons. The mechanism of cavatum is, the fluid inside circulates. First, you should pass the sound and you should know the uterocervical canal length. Then the balloon is inserted like how I have showed you earlier. And here the medium what you instill is glycine. The pressure utilized is here also 180 millimeters of mercury. The fluid is heated up to 75 degrees centigrade and the time taken is double than what we have used in thermochoice. It is 15 minutes. In the end, the balloon is withdrawn and catheter is taken out. This is called as cavatum. One practical difficulty is all these are made for use and throw. But in our country, typically we don't go by use and throw. We try to reuse. By reusing the technique and the balloons, the expected results are not achieved because all these instruments are made up for only one use. Once the balloon is inserted and you inject the solution glycine, the pressure desired is 180 and then you press the start button. Then patiently wait for 15 minutes. Here you can observe the fluid is rotating inside the balloon. Thereby, the designer says the results are much superior than the Dharma choice. In Dharma choice, the fluid is heated up and it is distending the balloon. Whereas in Kevatam, the mechanism is the fluid inside is circulating. Once the fluid inside is circulating, they claim it is a uniform distribution of the heated fluid and the ablation is much successful. So this technique is almost similar to the Dharma choice, but the difference is the time is double and the results are slightly better compared to Dharma choice. Most of these procedures I have used, but personally I felt microwave endometrial ablation is the easiest and the best method because in microwave endometrial ablation technique, what I have seen is the time utilized to do the endometrial ablation is very short. It is only 3 minutes. And another advantage is in all other endometrial ablation techniques, the uterocervical canal should be of normal caliber. If it is too small, if it is too large, these procedures cannot give the result expected. And if there are fibroids, even intramural fibroid distorting the cavity, the previous techniques may not give the best results. Whereas the beauty of microwave endometrial technique is even the cavity is large, cavity is distorted with the fibroids, it can give a good endometrial ablation and endometrial ablation results are much superior. Let us see the procedure. Here the probe is passed. You have to gently rock your hand to move the probe from one corner to the other. Through the microwave energy, the ablation occurs. Because the probe is thin and it reaches all the corners, and even there is a underlying fibroid, the cavity is distorted, this technique successfully ablates the endometrium. What I felt comfortable in this procedure is we have a graph which shows whether we have to stay in the same spot for a few more seconds or we can move. I will show you the graph. You have to maintain between that graph. Suppose it is dipping below the graph, just stay back in the same place for a few seconds. If it is maintaining on that graph, you just keep moving and eventually, believe me, in 3 minutes, the entire procedure is successfully done. But I only felt that initial cost is very heavy and the recurrent expenditure is also very heavy. Otherwise, this procedure would have become very, very successful procedure and very popular procedure. This is what I told you.
Progresses in
Here
this fashion with gradual.
We have to maintain within this zone. The microwave energy used at a frequency of 9.2 gigahertz. The depth of destruction is 6 mm. The temperature it reaches is 70 to 80 degrees centigrade. Doing is believing. It takes only 3 minutes. Success rate is as high as transcervical resection of endometrium, and the patient satisfaction ranges between 70 to 80%. So when it dips below, you have to keep the probe there in the same place for few more seconds. Then your probe will give, you have to be in this area. If it is going beyond that and going to red zone, start moving your probe. In one case, doing hands-on, you can learn this technique. That is what I felt. If it would have been there, it would have become very popular, because many people very quickly, in 1 or 2 cases, they learn the technique. But the cost was very, very expensive. So in one study where they have analyzed the result, more than 250 women. So the satisfaction of both the procedures is same patient point of view. The time taken is, microwave endometrial ablation is 3 to 5 millimeters only. In TCRE minimum you need 15 to 20 minutes. Amenorrhea is achieved in both the groups up to 40%. And after 1 year, the number of women who had the need of hysterectomy was 7 to 9%. The most important point is, compared to TCRE, microwave endometrial ablation is very, very easy, very quick to learn, and very easy to get adopt. So this is an important slide. I want my students to concentrate. What are the important considerations in these techniques? The most important is, whenever you are ablating the endometrium, it is mandatory that you should have a endometrial sampling to exclude any atypia, any malignancy. Uterine cavity assessment through a transvaginal ultrasound or saline infusion sonography or office hysteroscopy is very value adding, because you are using a blind technique in passing the probe. So you should exclude uterine anomalies, you should exclude polyps, and you should have a clue of the uterine cavity which you are going to ablate. You have to discuss with the patient, obtain an informed consent, and you should give her the option. It can be performed under local anesthesia or minimal sedation, unless the patient is very, very apprehensive. Endometrial preparation is device specific. Paracervical block may be of great help, because after the procedure, the spasmodic cramp-like pains are much less and the patient is comfortable. It is needless to say, you should have an informed consent. Routinely, if you are doing in the OT and aseptic precautions, not like major surgical procedure, no antibiotic prophylaxis is required. And anesthesia is also not mandatory in many of the cases, unless the patient is requesting for it. This slide is a comparative slide which shows what are the advantages and disadvantages of each procedure. When it comes to the cavatum, the energy source is the heated solution ablating the endometrium through the thermal balloon. No need of hysteroscopy with this procedure. Cervical dilatation up to 5 mm is adequate. Only thing is, the cavity should be more than 4 centimeters and less than 10 centimeters. The treatment taken is 10 to 15 minutes. And usually no specific treatments it is required. But if the endometrium is very thick, polypoidal, maybe you have to do the curettage. It is always mandatory to rule out any atypia or pregnancy. And gross uterine anomalies, cavatum is not a ideal ablation technique. Coming to thermochoice, it is more or less same with cavatum, but uterine cavity volume up to 30 ml it can be utilized. If the cavity is up to 2, it can be utilized. So except these two, more or less the advantages and disadvantages are same. The time taken is 8 minutes, double for the cavatum. Coming to cryoablation, in this also there is no need of histoscopic visualization. The cavity is once again 10 centimeter is ideal. Time taken for this procedure is nearly 15 to 20 minutes. And if there are polyps or leiomyomas, once again it is not suitable. Some of the studies have recommended GnRH analogs may help in getting better results. Coming to other techniques of hydrothermal ablation, that is first one which I have shown where the temperature is increased to 70 degrees centigrade. In this, the cervical dilatation required is up to 8. GnRH analog may be of some use. Once again, submucous polyps and myomas is a contraindication, and even the uterine leiomyomas, even intramural, if there are there, this procedure may not give you the adequate results. Coming to NovaSure, it is a radio frequency electrical surgical procedure, and dilatation is required up to 8 mm, and treatment time is only 1.5 minutes, and the contraindications are same. Coming to endometrial ablation technique, I personally felt out of all these procedures, this is easy and less time consuming, and the results are good. The dilatation is required up to 8.5. The cavity could be up to 14 also. The dilatation is only 3.5 is adequate. GnRH analog agonist may be of some use but not mandatory. Mechanical dilatation should not be done when you are performing this technique. And complications compared to other procedure, microwave endometrial technique complications are much less. In general, comparing all the procedure, what are the complications with endometrial ablation technique? Some are intraoperative, some are immediate postoperative, and few are very late onset. Intraoperative complications, especially once you are using the media in transcervical endometrial resection, the fluid overload and energy sources complications are there. There could be perforation of the uterus, thermal injury to the uterus or adjacent organs, or malfunctioning. These are very rare because nowadays we are having very higher end equipment. Needless to say, the more you invest in the equipment, the more comfort you will feel. Post-operative complications, like any other surgical procedure, there could be infection or delayed expression of thermal injuries, either mechanical or thermal. Most commonly, the patient complains of cramp-like pains, rarely, unfortunately, mortality. So one more question to the postgraduate is, in the next class, you tell me what is post-ablation tubal ligation syndrome. Or anybody already with the answer, they can put it in the chat box. Because you are ablating the endometrial cavity, when the heated probe you are bringing out, cervical canal also may get burned and cervical stenosis can occur, and the sloughing material and blood can become hematometra. That could become a source of infection. So hematometra and infection secondary to cervical stenosis can be there. So one more important point is, if there is a occurrence of malignancy, detection in post endometrial ablation techniques is very difficult. We may miss. That's why it is mandatory to have a endometrial ablation. Before you do, you should have a endometrial biopsy. Sarita, there are some questions. Should I stop and answer the question, or can I answer in the end? Radhika?
I think, hello?
Should I answer these questions, madam, or I should answer
I
in
think
the
we
end?
can finish the entire presentation and then we'll take up the questions.
Okay, madam. Thank you so much. Thank you. This is my imagination. This is what I dream. What is impossible today is going to be possible tomorrow. This is my robo. I feel a day is not very far off where we will have a robo through the hysteroscope, and we will give a command, go and take a biopsy. It takes the biopsy. And in next case, we will give a command, go and do the polypectomy. So the robo goes through the hysteroscope, performs the polypectomy and comes back. Suppose there is a submucous myoma, you tell the robo, here is the location, you go and do resection. So it does the job what the surgeon wants and comes back. This is my imagination, but I feel the day is not very far off. Coming to the other conservative procedures, we will discuss about intrauterine systems. Intrauterine systems, as all of you are aware, Mirena has become very popular. It is a intrauterine releasing system of levonorgestrel. It releases 20 micrograms of levonorgestrel per day. It is 3.2 centimeters in its height, and it contains 52 milligrams of reservoir of levonorgestrel. The first year failure rate is 0.2%, and cumulative pregnancy rate over 5 years, which is the lifespan of this Mirena, is 0.7%. Though it was first designed for contraception, the observations of various physicians came to the effect that it can be used for AUBs also, because it was observed it is effectively controlling the bleeding, and in 20% of cases even it is achieving amenorrhea, and it has drastically brought down the incidence of hysterectomies, and it is very easily acceptable with the patient compared to hysterectomy, and beauty of it is reversible. So it is accepted as a contraceptive device in more than 100 countries. And for menorrhagia, nearly 100 countries it has been accepted. So once it is inserted, insertion technique can be easily learned. Target releasing of levonorgestrel 20 micrograms. Once you want to remove, you can remove very easily. It is an outpatient procedure. Proper counseling and consent and insertion, then you get the result. So it has a double action, contraception, as well as a effective method of controlling the AUB. I think I'm sure everybody utilizes it, and it is very, very popular method. The mechanism of action is, it is locally releasing levonorgestrel, suppresses the endometrial proliferation. The endometrium becomes thin and desudilization of the stroma occurs. It also causes thickening of the cervical mucus, though there are no hormonal effects or no effect on the ovary. It causes not only decrease in the menstrual flow, it also reduces the dysmenorrhea, and it also helps in reducing both spasmodic as well as congestive dysmenorrhea, reduces the local growth factor, and thereby it reduces dysmenorrhea, but it cannot prevent implantation, and inhibition of the fertilization is not its mechanism of action. I would like to share a very, very interesting case. When I've just come back to India, I was looking for Mirena. Mirena was not available at that time, and I got this girl who was 18 years of age, and she was brought to the OPD with a history of continuous bleeding PV, and she was severely anemic and breathless. She was a known case of arteriovenous fistula in the right lower limb from her birth. She attained menarche at 14 years of age. Since then, she had a severe menorrhagia. She has been to many doctors and everybody has treated her so well, but her response was very poor. Every time she was bleeding and blood transfusions were repeatedly given. The patient parents brought her saying that we want hysterectomy. I was very much worried how to do hysterectomy for 18 years, and all her prescriptions, what she has used by the previous doctors are also, everything was so good. And I said, even I can't do beyond this. What the medicine you have used was very correct, but just wait. We may get Mirena in India. With great difficulty, we waited for almost 6 months. Then, to her luck, to my luck, we got Mirena, and then with one hope, I inserted Mirena in this girl. She was noticed to have a hemangioma, and she was in detail evaluated by pediatric surgeons, plastic surgeons, and orthopedician. And to cut short, it was diagnosed as a AV fistula, and patient develops ulcers secondary to her stagnation, and patient had continuous bleeding and secondary infection. This helpless soul, even I was not sure whether the Mirena will help her or not, but my only hope was it may help this individual. So there's a video playing anyway. So we got her Doppler flow studies, and then her hemoglobin was 3 grams. We gave multiple blood transfusions. This video is not playing, but what she was telling is, I was fed up of my life. I wanted hysterectomy. Throughout my adolescent, I was using only medicines and blood transfusions. In the end, with little hope, I agreed to get Mirena insertion, and then thank God she responded. And after 5 years, I removed the Mirena, and I did a hysteroscopy, and I reinserted the Mirena. 10 years over, then luckily she got married, And this time she wanted a third Marina. I said, I don't have experience of inserting Marina for the third time. And anyway, now the uterus, the lining has become very much thinned out. Let us wait. So let us wait and watch. So we are in that phase. So I wanted to share this interesting case. Many medications were used for this lady, but Marina has helped her. I wanted to share her statement, but some of this video is not playing anyway. So coming to the intrauterine systems, the comparison between these two, each one is effective, but there are certain studies where they have done transcervical resection of endometrium and concomitant insertion of levonorgestrel, and they say it is a safe and the rate of amenorrhea has been increased, and these are small observational studies. So I do both the procedures. I do transcervical resection of endometrium, and we also do Marina. But post ablation, I have not inserted any Marina. If any of the faculty wants to share if they have done, I will be more than happy. So they say concomitant use of Marina after the endometrial ablation gives better results compared to individual procedures. All these, which method you choose depends on the age of the patient, clinical history of the patient, severity of the bleeding, the contraindication what the patient has, and how much she has responded to the medical treatment, what is her underlying medical condition, what is the couple's desire regarding their fertility, and patient's preference, all also dictates which method we have to choose. So with this, I conclude and thank one and all, and I am ready to answer your questions. So I will stop sharing, madam.
Thank you very much, Dr. Fahmida.
Thank you, madam. Thank you. It is my privilege.
That was, very well covered. And there are a lot of questions also at the same time.
Madam.
Dr. Radhika is also here today. Sarita is here. Sarita, are you still there? She must be, but I don't think she's probably heard us.
Yes,
so I
madam.
think we can probably take the questions if you would like to.
Yes,
Dr.
madam.
Radhika? I think we can go through the questions there.
Yeah, Sarita is there. Sarita, you can start, I think.
Sarita?
Yes, Dr. Master.
Do you want to take on the questions along with Dr. Fahmida?
1 second, I'll just open the chat box. Yeah, so this first start with the first one.
Well, before we go any further, let me tell you, Dr. Satya Shivani said, best class, ma'am. Congratulations. It was a very good class.
Thank you, madam. Thank you so much. Very encouraging.
No, it's the students. So the proof is in the, of the pudding is in the eating.
Madam, it is all you have given me an opportunity. I'm thankful to you.
So all my colleagues, etc., and Navneet also said that you had shown an interest. So I said, why not? Let's take it.
It's an addiction, madam. Teaching is an addiction.
Great.
He was my teacher, Dr.
Sarita?
Dr. Fahmida was my teacher.
Oh.
Sarita was one of the
Hyderabad.
Uterine cavity, and there is some distinction depending on the kind of instrument that is used for thermal ablation. So ThermaChoice, for instance, so that cramping and discomfort. So it's, I think now we have the parenteral paracetamol available.
Yes.
So I think that is also very effective. And then one can also consider giving rectal suppositories. There are we also, those tablets, especially, with HSG, wherever there is uterine distension, it's our experience that they're very good to use. So the quality of life is very good. And, immediately after the surgery also, the pain is also greatly, the discomfort is greatly reduced to a large extent. So that can also be given a consideration, I think.
Yes, definitely.
No, I think, yes, that's absolutely right. That suppositories do, give another added dimension to the analgesia. But if they are given before the procedure, then they have time to act. When you are
Yes,
also
at
doing the
least half an hour
procedure.
before the procedure.
Yes.
And one can use small parental formulation.
The other thing is there is no hard and fast rule that you have to give a local. It will depend upon the patient profile also. And sometimes you may actually require a general anesthesia also. So it doesn't mean all of them can be done under only local anesthesia. This is one thing that the students need to understand, that for every patient, everything, whether it is anesthesia or the procedure or anything, it is very individualized. And that you must always keep in mind. If in doubt, please speak to your anesthetic colleagues. Don't think that because you've learned that you have to do it under local anesthesia, that is only what you have to do. Okay? So
even regional is acceptable.
Yes.
It can also be done under
many
subarachnoid
of them
block,
are done in
spinal.
regional. The only thing is in daycare, sometimes the discharge may
Yeah.
be a bit delayed, and that is something that you will have to keep in mind. So it will depend upon that individual, but local. And when you asked about, as Dr. Fahmida said, you can use any needle or syringe, but previously people used to use the dental syringe and the needle because that, managed to enter the cervix more easily than, the ordinary needles. So the dental
So now
syringe
we
and
use the
needle.
spinal needles actually. The ones which are used for spinal anesthesia, so they are also very long.
Yeah, and it enters the tough cervix easily.
Yes.
Yeah.
Normally,
The length as well as the.
Yes.
Yeah, especially I think for anesthesia is needed for if you're doing a transcervical endometrial resection, because then the hysteroscopic, especially the hysteroscopic procedures, for the fluid balance, and the anesthetist keeps a watch on, we have to account for how much fluid is going in and coming out.
And I think one shouldn't, sorry to interrupt. No, carry on, Sarita.
No,
What
to
I have
avoid
to say.
fluid retention, because that can be a major problem in hysteroscopic.
Yes.
So what my recommendation would be, whenever you start any of these procedures, don't start straight away saying that I will do it in the OPD by myself. Please do things under supervision first. Initially, you can start till there is a learning curve for everything. Do it under anesthesia for most patients, and only then you graduate on to doing it in the OPD by yourself independently. So everything has a learning curve from that point of view as well.
Yes.
Yes, Sarita?
Yeah, so the other question is, does it increase the risk of ectopic pregnancy? And is there an increased risk of placenta accreta spectrum after endometrial ablation?
Dr. Fahmida?
These two questions are little different. Now, let me first answer ectopic pregnancy risk. Further pregnancies should not opt for endometrial ablation. If they are going for endometrial ablation, they should not plan the pregnancy, because you have burned the endometrium underlying basal layers. There will be high risk of placenta accreta, percreta. So they should not plan the pregnancy.
Another point, Dr. Fahmida, I was just wanting you to also confirm.
Madam.
So do you think it's a good idea to post these women post-menstrual, and also, because, for instance, ThermaChoice, the company itself says, you do an endometrial aspiration, do a DNC before you do the ThermaChoice ablation, because it further thins the endometrium, and the chances of success are more. So it is always a good idea to do the procedure when the endometrium is thin. That is number one. Number two, one of the disadvantages here is that the the corneal part of the endometrium may not be adequately ablated. So in fact, that is at risk for an endometrial malignancy. So following a thermal ablation, if there is Asherman syndrome, there is a possibility that access to these areas might be difficult, number one. And number two, there could be a failure. You know, the women could, what they expected to have amenorrhea may not be happening, and some percentage of women continue to have their menses. So these are a few things, you know, which are to be kept in mind by the clinician. Not all books say this. You know, they don't highlight these clinical aspects and the practical aspects of managing these cases by ablative methods. And the biggest disadvantage of these ablative systems is that we don't have the endometrium of that day. Of course, you would have sampled it, we have done a hysteroscopy and all that. But if there are these procedures which say that don't do hysteroscopy, there is no need, just do a straight thermal ablation. So ablation means no histopathology available in your hand. So it's a must. You have also adequately emphasized, and I would like to reiterate that it is so important to have a pap smear in hand. Number two, it is very, very important to have the endometrial sampling. So the preoperative procedure would be probably a fractional curettage, meaning the endometrial sampling with an endocervical curettage to be adequately sure that everything is well, along with the pap smear. So that should be an important point in the preoperative preparation of the patient.
And another thing, taking on from this, I would like to add something else. You know, these days I have seen an increased tendency for some people. They say, okay, on the table, we will do everything in one sitting. We'll take some endometrium, send it off a frozen section. And thereafter, if the frozen section, they say it's all right, then we'll carry on with the procedure. But they must remember the limitations of a frozen section and the inadequate part of the sampling. So they may end up doing a procedure who may actually be a potentially malignant person. So this practice should not be encouraged or followed. And I thought I would make this point at this juncture, that don't depend on a frozen section and do it at the same time. Because especially in the private sector, people might say, okay, uska bill बढ़ जाएगा, 2 बार खर्चा. Let's be a proper, thorough medical professional. And don't let the finances of the patient enter your medical management or treatment.
I think that's a very important point.
Very well said, madam. That is absolutely correct.
Yes.
Because frozen section is not for these endometrium.
Absolutely.
That is only for a very different scenario for the ovarian pathologies where you are unable to decide whether you have to do conservative or radical. Here, as you said, if you are concerned about finances of the patient, forego your fee, but don't compromise in the quality.
The quality of the treatment.
Quality of the treatment. And Radhika also has nicely emphasized the possibility of malignancy. That's why we kept on telling endometrial sampling preoperative mandatory. One more point is, even on the long term post endometrial ablation, God forbidden if the patient develops any sort of malignancy, there is a high risk of missing the lesion because the endometrium will be very patchy and we may not able to get the right sample. That's why if there is any family history of malignancy is there, you have to think twice before you jump and take these patients for endometrial ablation. And one more important clinical point is, whenever you do procedure, you tell them this is not the final procedure and you never like to come back to the hospital. You come at least once in a year and get your ultrasound to see whether there is any regrowth of the endometrium, as rightly Dr. Radhika said, especially on the corneal areas. Because most of the procedure will not ablate the endometrial surface near the cornea. Only the microwave endometrial ablation is the one where we could reach up to the cornea and ablate. But rest of the procedure, there is a possibility of missing the cornea. Because I do very often hysteroscopy, I personally also felt even in doing blind DNC, the possibility of missing the lesion is near the endometrium, near the cornea only. So whereas if you do hysteroscopy, you see the cornea, then only your procedure is complete. Thereby, the missing of endometrium chances will become less in detecting the malignancy.
And therefore, as Dr. Radhika said, fractional curettage, the cervix and the endocervix. Because quite often we find when the procedures are being done, you go right up to the fundus. Everybody is making an attempt to go up to the fundus, and they are taking samples from the walls of the uterus. And very often the malignancy may be just above the isthmus.
Correct.
And it's very likely that you might miss it unless you have taken care that you just enter and you take the endocervical, lesion and the biopsy properly. So that is very important. Just above the isthmus is one of the parts where I've seen it being missed most.
This is also very valid point. So while entering or while coming back, concentrate on the cervical canal and lower part of the uterus.
Yes.
One more beautiful point of hysteroscopy is when you are almost coming out, stay back for few minutes, look at the squamocolumnar junction. You feel as if you are diving under the sea and seeing the underwater beauty. The columnar epithelium will be moving its
like the sea anemone.
sea anemone. It is really beautiful, and you feel as if you are doing a colposcopy. Because all the colposcopists will like to see squamocolumnar junction. See the squamocolumnar junction through the hysteroscope and you enjoy it.
True. Very true. The pleasures of doing procedures at times.
Yes.
Sarita?
Yes. Can you hear me?
Yes,
Yes,
yes.
Sarita.
Okay. So in thermal ablation, there is this question about thermal injury to adjacent organs.
See, thermal ablative techniques, the adjacent organ injury depends on the procedure which you have chosen. Each procedure has its inherent risk factors. See, for example, you are overdoing the procedure, there is a possibility of underlying myometrium getting necrosed and thereby increased chance of infection. But nowadays, all these higher end devices are having inbuilt time factors. They will get automatically switched off. For example, Dharma choice 8 minutes, it will get automatically switched off. Cavatum, after 15 minutes, it gets switched off. There is nothing like over treatment. Whereas in other procedures also, you have to be very careful and you should stop the procedure once you achieved your required goal. It is very rare to go beyond the myometrium and do damage to the either bladder or the rectum, though in the literature some cases are reported. It is very rare. These complication of adjacent organs is more with the transcervical resection of endometrium, where you are having a receptoscope in your hand. Without realizing, you will be just cutting through the myometrium. So you have to first do a lot of diagnostic procedure, then you should start doing resection of the endometrium. Compared to the transcervical resection and the other thermal ablation techniques, the complications of transcervical resection of endometrium causing adjacent organ damage is relatively more.
Yeah. Okay, so the other question is what is the criteria or indications for hysterectomy after ablative procedures have been performed? So in other words, what is the success rate of these ablative procedures, and what is the of these risk of recurrence of these symptoms after ablative procedures are performed?
You want to answer, Sarita, or should I answer?
No, please, you are the expert in this. So
ऐसा कुछ नहीं है रे. See, each ablative procedure has a different success rate. Usually, these success rates varies anywhere between to 70 to highest is 93%. There is nothing like 100%. So those cases where it could not give the hypomenorrhea or amenorrhea and the patient continues to bleed, these are the cases you have to take for hysterectomy. When the results were analyzed, nearly 8 to 10% of ablative technique long-term follow-up more than a year, they underwent hysterectomy. And nearly 10% of the patient needed hysterectomy. If the procedure is satisfactory and the results are good, your selection of case is good, it is as low as 3 to 5%. So your selection of case, the method you have chosen, the way you have performed also contributes to the hysterectomy rate. If everything is perfectly selected, perfectly done, then the follow-up rate of hysterectomy is around about 5%. If the method is not properly selected and the patient did not had the desired result, there is 1 in 10 cases needs hysterectomy after 1 year.
Yeah.
What is the next question? What is the
And what is
patient?
the amenorrhea rate, Dr. Femira? I mean, the
40% only.
40%. Okay.
So the counseling has to be very important.
Very true.
The expectation of the patient. We must address that and tell them very clearly that it is only 40% chance that you will have amenorrhea, and otherwise you may have hypomenorrhea, and also warn them that what are the times when they should report back, and that they need to be under follow-up. It's not that the procedure is done and they are gone for good for all their lives. No, they need to follow up.
And
At
with
the same time,
Mirena,
they have,
there
sorry,
with Mirena, there could be irregular spotting in the initial time because the progesterone release in the initial first 3 months could be very high, and that could have a progestational effect on the endometrium. And what the expectation is that she would have less bleeding, but then the problem is irregular bleeding, and that also needs to be told to the patient.
And whenever they have an ablative procedure, Dr. Fahmida has already pointed out that they should not be planning a pregnancy. So contraception after the procedure also needs to be discussed as to what stage you are doing that with them. That is also important.
True, madam.
Absolutely. So what is the patient position for the ablative procedures? Can the patient position protect from fluid overload to some extent?
See, in the hysteroscopy, you have to keep the patient in the lithotomy position. I think there is no other option except putting the patient in the lithotomy position.
True.
Position itself cannot cause fluid overload. Madam, if you permit, I will tell few things about fluid overload.
Yes, please do. Please do. Please do.
Why fluid load is happening? You are resecting the endometrium. So the blood vessels have opened up. At the same time, you are pushing the fluid under pressure. So there is extravasation of the fluid into the blood vessels, and fluid is getting absorbed into the vasculature, and it is getting lot of hyponatremia. That is a dreaded complication of fluid overload. The patient, if you are doing under regional anesthesia, if she is conscious, she may start complaining of dizziness and reeling sensation. And if the procedure, sometimes you do very lengthy procedure, there could be 2-3 big fibroids propping in, like FIGO type 2. Once you start resecting, it will be propping into the cavity more and more. You cannot leave the procedure unless you want to do in 2-step. You start resecting, and you get involved in resecting. You don't realize how much time you are taken. That's why you should not have ego, and you should listen to the anesthetist and respect their warning. Sometimes the anesthetist said, "Madam, you have exceeded 40 minutes. Now you stop." You stop the procedure for sake of safety of the patient. And it is not a bad idea to give Lasix once if there is an early suspicion that there is a negative fluid balance, that is what you have injected is more than what is coming out of the outlet of the receptoscope. You give Lasix to the patient and catheterize the patient, send the sample for a blood sample for electrolytes and CBP and PCV. So whether there is a drop in the hemoglobin whether there is electrolyte imbalance, immediately stop the procedure. Don't be over enthusiastic to do the procedure in one sitting at the compromising the safety of the patient. Second most important thing is the fluid which you are chosen. If you are having monopolar cautery, because in the beginning to buy a bipolar cautery which is very expensive, people try to buy monopolar cautery. You start resecting with the monopolar cautery, the medium what you are using is glycine. So
Yes.
100 ml of glycine if you use, that will attract 800 ml of fluid. Whereas if you use normal saline, even 1.5 liters of fluid also patient get absorbed. It is safe. You have to just give away 20 milligrams of IV Lasix. So there is a lot of difference. If you are able to use that much of fluid, you will complete the procedure with that much of fluid. Usually we use 3 liters of bottles, and we will be having input on output observation. And as I told you, you have to be comfortably accept anesthetist or any colleague suggestions. You should not be egoistic to say, no, 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 give me some more time, I will complete. No. If
Absolutely,
any
very
colleague
true.
says stop, please respect that and stop the procedure. Catheterize the patient, see the output, and look for the electrolyte reports. This is what I can say, the fluid overload protection protocol. It is not the position of the patient, because you have no other go except putting the patient in the lithotomy position. If you are asking about whether it should be head low or no head low, these are secondary. They are not going to give any difference in fluid absorption or fluid overload problems.
I'm glad you dealt at length with this particular point because
Madam,
people
thank you,
have
madam.
had a listen. Thank you very much.
Thank you, ma'am.
Yeah, there's another interesting question about post-ablation tubal sterilization syndrome. Is cyclical pain due to tubal distension from occult bleeding into obstructed tubes?
Yeah, this question I have asked because any ablation technique can cause post tubal ligation syndrome. What is it? So Dr. Nidhi Gupta has answered it. Yes. Extension of this answer is these patients will have cyclical dysmenorrhea. They also have dyspareunia. Sometimes they will have menorrhagia. Sometimes they will have depression. Sometimes they will have even loss of libido. So all these can occur with these procedures or any tubal ligation. This is given a name of post-tubal ligation syndrome. All the spectrum of symptoms can manifest in these individuals. So it also applies to the ablation techniques.
Yeah, it's good that they're asking all these questions. That means they're thinking, they're listening, and also
Yes.
yes. Okay, so there's another question about menstrual irregularities post tubal ligation.
Anybody wants to answer? This is
Radhika,
tubal ligation, no? Anybody can answer.
Radhika, please. Just looking at the other.
Sarita, I
The
didn't hear
students
the
were to
question.
answer.
What was it?
What? Why about menstrual
Menstrual
irregularities?
post-tubal ligation.
Why do they have menstrual irregularities?
So I think the students should answer themselves.
I
So
thought
what is the vascular?
it was the students who were going to answer.
Yeah, it is too. So what the clue is? What is the blood supply of the ovaries? Where do the ovaries get their blood supply from? And what is it there in the broad ligament? So when you ligate the tubes, what happens? So just think about it, and then probably you can start answering. Why should there be a post-ligation menstrual irregularity? And what percentage is it to be something, how it is to be managed? Meaning, is it something to be worried about, or is it to be managed? What happens to these ladies later on? So if people are not able to answer this time, you can read up and probably answer it next time.
Okay, so there's another question about, does endometrial ablation increase the risk of ectopic pregnancy?
I think we discussed, no?
Yeah. So it doesn't increase ectopic pregnancy, but yes, certainly there could be implantation problems, improper implantation of the placenta, accreta, morbidly adherent placenta. I think all this was discussed. Dr. Famida did mention about all this.
So among Mirena and I think they means ablation, which is a better option for unmarried girl with menorrhagia.
Hmm.
I think I have showed you a very beautiful case, isn't it?
Hmm.
Yeah, that is very illustrative. How to
Very
manage?
interested. And no
Okay,
question of
that could
ablation in unmarried girls because you cannot compromise their fertility.
Hmm.
Yes.
Can I ask you, you know, after this Myrina, her menstrual problems were solved. Did it make any difference to her legs?
The leg is same, madam. In fact, over the years, slightly it has increased, but it could, thank God, resolve her menstrual problem, but not the leg problem, madam.
Okay.
I'm just thinking this, Mirena, because we do get this many cases with AV malformation following DNE. I mean, they developed these AVMs and they keep having irregular bleeding after uh, having a DNE for a miscarriage.
You mean
So
evacuation, Sarita?
yes,
Dilatation evacuation, okay.
so I'm just thinking maybe we can try this because these are very
Yeah,
Can I
Sarita, it
answer,
is
Then
madam?
after that,
projections
no,
are
giving them
known to be
progesterone is good enough.
just
exactly.
No, shall I answer,
What you do
madam?
is that you put them on
OCPs.
progesterone,
hmm.
norethistérone or something like that, anything which can control the bleeding, give them for a cycle of 2-3 months. So far, it has always worked.
Even OCPs are quite useful actually.
Yes. So no procedure intervention, it has not been required so far. And in fact, later on, I did notice one thing, because those patients have been following me up from the time that they were young girls to the time now that they are perimenopausal, that those who had problems after the evacuation and the bleeding continued or even after menstruation, all the investigations were normal, but they had more menorrhagia even in the perimenopausal, abnormal uterine bleeding incidents later
Okay,
on in life also.
okay, okay.
Though in between
I
they may
took
have been perfectly fine.
I
Right.
have an interesting experience like Dr. Famida. She talked about this girl who was 21 or she was around the same age. So this girl diagnosed factor 7 deficiency who had coagulopathy. So once she attained menarche, she bled like nobody's business. So we used thermal ablation for her. So she responded well. She developed amenorrhea initially, followed by controlled bleeding. Now she is married and she is much better and all that. So sometimes for those kind of unusual presentations also, these ablative procedures can be used.
Ablative procedures I have used in one patient who is almost blind with retinitis pigmentosa. I have used in a patient who has a severe rheumatoid arthritis patient who is not even able to walk. These are the patient I did endometrial ablation and the results are good. But honestly speaking, the drawback is you have to use single use and throw the balloons. We are not able to do to cut down the cost, then the results are not good. But at least these desperate individuals, if you are using, please use a new balloon. Then only you will get the good results. Reused balloons will not give the desired results in ablation techniques.
So I think it is also important for us to, Sarita, are the questions over?
There's one question: how to manage irregular bleeding with Mirena?
It is
I think,
frequent.
okay, you go ahead. I think
No,
Dr.
madam,
Famida
please.
first, then I will.
Madam, आप बोलिए, madam, please. आप
No,
बोलिए.
my question, yeah. How to manage irregular bleeding after Myrina? I can only say from more of a personal experience that when I choose a person to put in Myrina, I put them on norethistron for a couple of cycles. If they respond to those, then I think they have a higher chance of succeeding with Mirena.
Yeah.
No, but I think that's
If you put Mirena in and they still have intermenstrual bleeding, then you can, over and above the Mirena, you can give them progesterone for a couple of times, and then afterwards most of them settle down. If they don't, then you need to go back and look at the ultrasound reports, etc., because many of them with diffuse adenomyosis and other problems do not always respond to Mirena.
True. Yes, absolutely. Yeah.
May I add a comment to that, Dr. Basu?
Certainly.
This bleeding is because of the progesterogenic effect. I think we were discussing that earlier
Yes,
also in this
yes.
session. So it is also probably a good idea, which we find with reasonable success, that you add estrogens for 7 days.
Mm-hmm.
You just let that endometrium grow. So the chances of that lady responding is slightly better, because it is the atrophy of that endometrium, because the initial release of progestogens is quite high, and then it settles down to 20 micrograms per day. So
Mm.
initially, because of the increased release, the decidualization of the endometrium is actually the reason for, other than the aseptic endometritis and all that.
No,
So other
you
than
have a
what we
valid
have
point.
discussed, it might also, yeah.
No, I think it's a very valid point and it may be worth trying. The only thing
Yeah.
what I find is that before I put in Mirena, over a period of time,
Absolutely.
having trial, I give them a trial and I know which are the ones.
You press the button start. Once you press the button start at the 87 degree centigrade, automatically it will stop by itself at 8 minutes. Is
Does
it
that
the
There is no need to move. There is no
move
need to
the
move the balloon. It
balloon?
will,
move?
because
Need to
because
move.
once the balloon expands, it conforms according to the
Shape
shape
of
of
the
the uterine
uterus.
cavity.
Hmm.
So
You
of the
should
uterine cavity.
move.
So one should not actually move it. Keep it stable.
Only thing is, because the endometrial cavity gets expanded, your pressure drops. You just inject few
A
drops,
little
1 ml of 5% dextrose. Again, the pressure will come back to normal. So you have to have an eye on the pressure.
pressure.
Without disturbing the balloon, you just keep your fingers on the syringe and gently inject. Once or twice, 1 or 2 ml, that's it. 8 minutes time you wait, it will be over. But need not move the balloon, you should not, because the balloon is containing very heated temperature inside. So if you bring down, it will injure the cervical canal and cervix. These are the cases will go for stenosis. So don't disturb the catheter. Your aim is to burn the endometrium, not the cervical canal.
Yeah. So, and there's one, I think that this will be the last question. Why submucous fibroid is a contraindication for ablation? Is it because the endometrial cavity is displaced, or is there some other reason?
You cannot ablate the endometrial cavity because there is a submucous fibroid hanging. You have to resect it. Then you can do, if there is a thickened endometrium, in addition to the submucous fibroid, you go ahead and do resection of the endometrium. Or if you are not confident about resecting the endometrium with the receptoscope, take out the bits of submucous fibroid and ablate the endometrium. But keeping the submucous fibroid which occupies the cavity, how will you ablate? You cannot ablate. That is the only contraindication for the most of the thermal ablation techniques.
Another
Somebody
question.
wants to know which equipment you use at your center. Dr. Sapna Malhotra.
I am crazy of equipment. You name the equipment, I have used all these equipments. Now I have settled for very higher end underwater bipolar cautery and my receptoscope. I am a crazy woman. I have 3 sets of receptoscope, 4 sets of laparoscope, even 3D rotating Olympus. My husband says women convert their money into jewels. You convert them into equipment. I'm that crazy, my dear.
Yeah, that's great. No problem.
I have Dharma Chais, I have Cavatam, whatnot. वो लड़कों को कारों का क्रेज था ना मैडम, मेरे
आपको
को
equipment का
इक्विपमेंट क्रेज है.
Which one do you like best and use most?
Transcervical resection of endometrium. I used all. Now I settle for transcervical resection of endometrium. But personally, even I liked microwave endometrial ablation. I tried to bring it to Hyderabad, but it was beyond practical. It was huge expenditure, so we dropped in between. But
Okay.
if somebody can keep it, it is very good. Because the learning curve is very easy. One case you do on the module, second case you can do on the patient. That easy. So for the people who wants to learn quickly and want to use in their practice, the microwave endometrial ablation is very good.
Yeah, I think that was an
Right.
excellent.
The second thing is too much expenditure on the equipment. Even our patients cannot afford. What is our aim?
Yes.
The aim is eventually our technology, our scientific temperament should benefit the patient. You have equipment, but you are not able to help the patient. What is the use?
Very true.
Yes. Yes, I think that's all with the questions, Dr. Basu. So over to you for your
No,
comments
I
and
think no, I think that was an excellent talk. And from the questions from the students, I thought they have understood, everything that you have explained because the questions said so. And Dr. Radhika, would you like to, say something before we wind up? Because it's
there is
No, I
already
think
6:50.
just interrupt, and there is one question from Dr. Sorup Ranjan Nanda, and they and he or she wants an answer. Can we use mitomycin C to counter the stenosis of the cervical canal?
What is the question, Sarita?
Can we use
can't.
the one complication is stenosis of the cervical canal? So can we use mitomycin C
Mitomycin
Before
C.
or after stenosis?
after stenosis? If there is
After
stenosis.
stenosis secondary to the endometrial ablation?
Yes.
Maybe I had no experience because I didn't got
I
any
don't have any
cervical
experience.
stenosis after that.
So you should, the aim should be to avoid cervical stenosis. But I've not used, nobody, I've no experience with using mitomycin.
Sarita, some of
Yes.
the
It's actually
students are
used in.
writing. Some of the students are writing messages privately because it is a group discussion. I request them to put their questions in the group
Questions.
so that I can answer.
Hmm.
So instead of writing privately, please write in the group. We will enjoy your questions.
I think mitomycin C, from what I can recall, is used in by the ophthalmologists to prevent scarring and adhesion. So I don't know whether I have not heard or not used mitomycin for preventing cervical scarring. What about you, Dr. Radhika?
no, I think there could be various institution and their people have their own personal experiences. So there are students working with them uh, for the clinical practice as well as for the exam. I think it has to be standard procedures which is accepted and which is taught. The standard clinical practice needs to be talked about. Of course, these kind of discussions can be taken up in conferences and workshops sort of a thing. But for the students, it's important for them to focus on the exams and also the clinical practice, the basics. So that was the reason I was, in fact, wanting to also give a few questions which could be asked in the exams, like, what are the various conservative procedures. So all, Dr. Famida had told us about the various generations of ablation, the starting from the first till what is available today. So, what is the questions could be like a short notes on the recently developed and accepted methods of endometrial ablative techniques, and why TCRE used to be very popular, say about 10 to 15 years from today and not anymore so. So, is there a reason why? What are the various disadvantages of an endometrial ablation, and what about TCRE? What is the current status, and what is the evidence say regarding TCRE, who are the eligible candidates and what are the pre-operative requisites. So these are a few points which could be asked somewhere. May not be short notes only, it could be practicals somewhere, wherever you get the instruments when you talk about them. So these are a few points. Of course, fluid management is extremely important. And what are the post-operative examination points, especially where you expect the fluid overload has taken place? How do you monitor such a patient? So as has already been spoken, I think one could also add about the ABG. So it is a good idea to have the pulse oximeter, monitor the lung bases, strict intake output chart, maintain a respiratory rate as well as the pulse and BP. So in the immediate post-op, at least for the first 2 hours, have a 15-minute close monitoring of the lady. So these are a few points which are important from the exam point of view, and the questions are similar to what is getting practiced, clinically relevant practical points. So I think Dr. Famida, it was a very informative session. So thank you so
madam.
much.
Thank you
Thank you.
so much, madam. Thank you. Thank you to Basu madam for giving me an opportunity.
Thank you very much.
Thank you so
Because it
much,
was-
madam. Thank you. Thank you, everybody. Dr. Sarita, Radhika madam, and the team leader, Navneet. Thank you so much.
Thank you very much, Dr. Famida Banu, for the presentation. And thank you very much, Dr. Sarita, Dr. Radhika, and Dr. S.N. Basu for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.
Thank you very much,
Thank you so
Navneet.
much.
Thank
Thank
you.
you.
all.
Thank you.
Bye-bye. Good night.
Bye.
Good, madam. Good.